So our next speaker is Dr. Axel Siu. Dr. Siu graduated from the Chinese University of Hong Kong and is also a fellow of the Hong Kong College of Emergency Medicine. And he's now the consulting in the Accident and Emergency Department in North District Hospital, but his another role is the medical director of the Hong Kong Fire Services Department. Dr. Siu has a lot of roles. He is the vice president of our College of Emergency Medicine, the vice president of the Resuscitation Council of Hong Kong, and also treasurer of the Asian Society for Emergency Medicine. All along, he has been very specialized and interested in resuscitations and pre-hospital care, and he is very active in teaching ACRS and BLS, and also ATRS and PHTRS. Now, so today, Axel will help us to revise some of the very recent guideline in CPR, which was published in the AHA and also the ICOR just last year, end of last year, is the AHA 2015 guideline on medical emergency and CPR. Dr. Siu, please.
Thank you, Dr. Ho, for your kind introductions, and also thank you for the organizer to invite me to attend this very fruitful and informative conference. But I need to apologize because I need to run from another marathon event this afternoon. But this is not a running event. This is a CPR marathon. We invite more than 1,000 participants to conduct the chest compression. And just my colleagues just informed me while WhatsApp, they told me that we have just achieved more than 1 million chest compression in 4 hours. So we break the world record. So I decided to wear the T-shirt as a CPR marathon to deliver the speech. So the topic I'm going to talk about is not an easy task because we're going to talk about the medical emergencies and what's new in the CPR AHA 2015 guidelines. And in fact, there are a lot of different kinds of medical emergencies that can be encountered during sports events, including heart attack, asthmatic attack, endocrine emergency, including hypoglycemia, heat-related illness, because sometimes in Hong Kong, the weather is very hot and humid, especially during the summer holidays. People will prepare for the trail walker. There are a lot of heat-related disease happen during the events, and now sometimes convulsions, syncope, and collapse. There are a lot of different kinds of medical emergency. But I just have 30 minutes time, so what I'm going to talk about is the worst scenario. This is cardiac arrest. So there are a lot of different presentations. There's and also a lot of history. This is one that we quote from a few years ago in the Hong Kong Marathon. There was a 26-year-old athlete who collapsed just after the finish line in the Victoria Park. And I think you know that the outcome was not good. And another event, just a clip from the newspaper. This gentleman collapsed while a football games, and this was my personal experience. I participated in a 10-kilometer race about 3 years ago around the Easter time, and I found athletes who collapsed in front of about several meters in front of me, and I asked the workers, the helpers at that time. They told me that the patient suffered from convulsions, but in fact, when I assessed him, he was in cardiac arrest. So I started resuscitations, and then fortunately there are a lot of other participants who helped to conduct the resuscitation. How about the outcome? I will tell you later. So in fact, the presentation of cardiac arrest this is not only restricted to collapse or syncope. In fact, there are a lot of the myth or misunderstanding by the general public that they may misinterpret that the patient was in convulsion, just like my case. And also, sometimes they may just think the patient was in gasping. The patient was still breathing by himself, but in fact, it is not a normal breathing, and the heart was stopped breathing already. So how about we focus on the athletes, okay? We don't have the overall figures for the Hong Kong athletes in all different kinds of sports, so I just quote the overseas statistics. In the incidents, especially we look into the marathon participants, 1 in 50,000 marathon participants, there will be 1 case of cardiac arrest. So in that case, you can imagine why we encountered the first case of cardiac arrest in 2006 in the Hong Kong Marathon. And No need to say, usually male will be more prone to develop cardiac arrest. We don't know why, probably will be genetic predispositions, and also probably because male usually will be involved in more strenuous sports. And just like Dr. Lobo said, marathon running, we can't avoid the risk. And, but we compare to the risk with other activities, you can see that actually, well, marathon in fact is more safe than you drive you drive a motorcycle. And so you can see then that in fact if we have some preventions or some strategy to treat, if an athlete develops cardiac arrest in front of you, we can still reduce the risk of the poor outcome. So this is the newly published chain of survival by the American Heart Association. They divide in two parts, but I will concentrate on the part on the out-of-hospital cardiac arrest. That is the 5 rings. Okay, the first ring mentioned about the recognition and the activation of the immune system. Second ring, immediate high-quality CPR. Third ring, rapid defibrillations. The fourth ring will be going to the ambulance. That will be the basic and advanced EMS system. And finally, the advanced life support and the post-cardiac arrest care. Well, every ring is very important. Losing or breakage of any ring will result in failure to survive, to resuscitate a patient. So, in order to go for the update, we're going to concentrate on one ring by one ring. For early recognitions, in order to achieve a good result, we must make a good and early recognitions. We need to detect the cardiac arrest as soon as possible. And secondly, we need to activate the EMS system in Hong Kong without 999 to call for the ambulance, because the ambulance, after activations, not only we will bring in the ambulance and they have the equipment, the knowledge and skills, but also in future there will be one more element that I will talk about. We can help us to save the patients, and that is the dispatcher's assisted CPR. So delay in recognitions. This is one of the major challenge for us to how to improve the survival of our hospital arrest in Hong Kong right now, because most of the case actually, most of the general public do not know that actually the patient is in cardiac arrest. Why? Because they may misinterpret that the patient was not in cardiac arrest. They may think that the patient is convulsions, seizure, and sometimes may think that the patient is still in breathing. In fact, the patient has just gasping. This is not a normal breathing, and the patient was in cardiac arrest already. Just like this case, this was Mac Vivian's Vo, and he was an international Cameroon soccer player. He represented his country for international friendly games in 2003 in France. And he collapsed while the games, and you can see then that not only the players, but also the officials did not knowing that the patient was in cardiac arrest. And so you can imagine the outcome. Basically, he died afterwards because of the delay in the starting of the resuscitations. So what we can do, probably education is very important. We must have a territory-wise education campaign to educate the general public the presenting symptoms of the cardiac arrest, so that they know the patient cardiac arrest, they need to call for help as soon as possible. If possible, they can start the CPR. School BLS program, well, in Hong Kong, we are much lag behind, because when we compare to other Asian countries, developed countries, for example, Japan, Singapore, they all have the national program in the school. Every school children, not only the secondary school in Japan, even the primary school students will have, they have a mandatory part to learn CPR, including the chest compression and also how to use the AED. Not only they can improve the skill, but also they can improve the thinking. They will try to help and try to initiate the skill to help people. And also we can mandate some of the job, for example, coach, and sometimes even the security guard to learn BLS, to make sure they have the valid certificate, so that they will be more willing to help people instead of just calling 999. As mentioned before, well, if we have to activate the EMS system, then we can call for ambulance, but there will be another part that we may be helping the people, helping the victims, because this is an element of dispatcher assisted CPR. This is highly emphasized in the 2015 AHA resuscitation guidelines. And what is all about the dispatcher assisted CPR? When we have the patients who collapse, and then somebody finding that the patient was in help. In Hong Kong, we have done 999 to the call center. When the call center receives a call, with some computerized preset system, they will ask the question to the caller. And after the assessment, they will find that they will make a diagnosis of cardiac arrest. In that case, they will initiate some instructions through the call receiver to the caller, and they will teach the caller how to conduct a compassion-only CPR. It is well developed in most of the developed countries in the Western countries. In Hong Kong, unfortunately, we do not have this system right now, but don't worry, because the government has put in resources, and hopefully this system will be implemented by the end of the 2017. And the second rank of the chain of survival will be the high quality CPR. High quality, this is not a CPR only, it's a high quality. What's mean by high quality? We must, in the past we said they push fast and push hard. We must push very, very fast, but now we are calling that it's adequately fast. That means we're not too fast, but not too slow. We must do it very adequate, but not too fast. The depth is also, we must do it with an adequate depth, but not too deep, okay? And also we make sure that the chest compressions should be continuous and without any unnecessary interruption, because by the study showing that when we stop the chest compression, it still takes some time for us to develop the adequate chest compressions and also the adequate cardiac output by means of the chest compressions. And also we make sure that we allow a chest recall to avoid, by means of we avoid unnecessary chest leaning. We don't put our hand, we lean our body or hand to the chest wall. Otherwise, there will be a hurdle to obstacle, we obstruct the chest recall during the chest compression. And finally, we try to avoid hyperventilation, because it will affect the cardiac output because of the decrease of the venous return to the heart. So how to achieve a high quality CPR? First of all, the compression rate. In the past guidelines, we are talking about at least 100 per minute. So that means we can make 120, 150, that's right. But now we will try to restrict it to 100 to 120, because we do too fast, it won't help the people, because when we are doing too fast chest compression, actually most of the chest compression achieved is not adequate, because there will be inadequate chest recall, there will be inadequate blood coming back to the heart for the next chest stroke. So we restrict it to 100 and 120, even though 120 is not easy. You can imagine that we need to conduct chest compression 2 times every second. So it is very, very exhausting. How about the depth? In the 20 guideline, we said at least 5 cm in depth. And the 215, we try to restrict it to 5 to 6 cm. If we are too shallow, that means the output, the cardiac output generated will not be adequate. But if it's too deep, studies showing that there will be higher chance to result in injury to the thoracic organ. So we try to restrict it to 5 to 6 cm. The chest compressions and the ventilation ratio, there's no change. In the past guideline, we talk about 30 to 2, 215. We still remain at the 30 to 2, no change. And the chest compression interruption, it is also emphasized in the 210 guidelines and also in the 2015 guidelines too. We try to restrict and to minimize any chest compressions interruption. And in fact, they also emphasize, because when we're going to prepare for defibrillation, there will be some pause. So we try to restrict this kind of pause as short as possible for both the pre-shock and the post-shock interruption. And the chest wall recall, as mentioned before, we try to allow adequate chest wall recall, make sure that there will be adequate blood coming back for the next stroke. Rescue breathing, well, For patient with, who has a pulse, but no normal breathing, we try to give one breath every 5-6 seconds. That means about 10 to 12 breaths per minute, and each breath to last around 1 second. But I'm not sure whether you have read the Chinese version of the AHA guidelines. Try to remain on the English one, because that the translation is wrong, because the original statement is over 1 second in this guideline, in the English guideline, but in the traditional Chinese version, it's because it's over, it says it's more than 1 second. So because this says that's so restrict, so we try to remain on the English version. Okay. So even we have this is the most of the update that I need to tell you, because in the 2015 guideline, on the BLS part, this is a major part, the major changes, or in fact, this is very, very minimal, okay? But now, even though we have to update the guidelines, we know the guidelines, even so, we still need something to do to improve the survival of the patient. What's that? We need people to volunteer to help. This is a study that I participated with the St. John, and we tried to perform a questionnaire survey. We find that actually, even though for those who know, before training, you can see that the percentage of willingness to help your relative was not very, very high. And even for stranger, you can see the rates for the willingness will be even lower. Fortunately, with some training, you can see that there will be some improvement, but in fact, there will be some deficit for those strangers. That means even you have trained, there was a stranger who collapsed in front of you. Some of the trained personnel will not choose to help, do not choose to start the CPR. That's a problem. What is the underlying problems? Probably this is one of the reasons why that Hong Kong has this poor picture, because of that we do not have this Good Samaritan's law. Good Samaritan's law saying that this is a law to protect everybody who willing to decide to help people, even though they have done something wrong, but because they just want to help. There was no any duty or any commitment in terms of the job or money, so that all these kind of wrongdoing will be protected by this law. So that everybody, with this kind of law, everybody should be more willing, more safe to conduct any procedure to save people. And actually, this kind of laws has been well practiced in most of the Western countries. And in Hong Kong, unfortunately, we don't have this law. And according to some of the first aid manual published by the Hong Kong Red Cross and St. John, they said that liability risk will be minimized if you have completed this kind of first aid training. We compare to some of the counterparts in Asian countries. For example, in Taiwan, they have this kind of law in 2012, and even in Shenzhen, something very close to us, because of one very famous event, a small kid who was knocked down by a car, and then nobody took care of her, and then they developed this law already. So you can see that actually most of the Asian countries, in Japan, Korea, Shenzhen and city, Singapore, they all have Taiwan, and only Singapore did not have this law, and we are much left behind. And so we need to go for the government to ask for whether they can help. The third ring, early defibrillation, we will be in the hospital setting. Most of the time, we will relate to the AED, the automated external defibrillator. Well, because in most of the case, airfares will be usually most of the time the cause of the sudden death for those airfares of age less than 35 will be because of the HOCM. And most of the time, HOCM will present with VF. So in that case, we have the defibrillators and the defibrillate the resuscitated patients as soon as possible. We can save the patient because, well, from this kind of from the overseas statistics, we knowing that if we delay in the defibrillate VF patients, there will be increase in a 7 to 10% mortality for every minute passed. And even if we have the chest compression, there is still the mortality will still increase by 3 to 4% for every minute delay in defibrillations. So probably how can we improve public education, as mentioned before, for the CPR cases? We need to have an AED promotion campaign and to make sure we try to install more AED in Hong Kong. We also make sure mandatory program for all the related occupation to have training in the AED. And the community PAD program is very important. Just like the case in Japan. They are very well-known and published program for the national-wide AED program, PAD program. In fact, they can improve the survival for a lot of rehab patients. And the paper was published in New England several years ago, and was well recognized as a major milestone in their country. But probably if you read the backstory, why they can they have this kind of the program, because one of the major persons in the royal family died, and because of the lack of the use of AED. So afterwards, they start the program. So just a joke. I always tell someone a joke. Probably we may need one major person in Hong Kong to sacrifice his life to alert the Hong Kong government that's the importance of this kind of campaign. So in Hong Kong, we have some AED programs already, and we have AED installed in Hong Kong International Airport, major theme park, shopping malls, and some of the residential buildings. But for Hong Kong International Airport, you know where to find the AED? You can go to the customer service department, you can find one. And you know, the Hong Kong Airport is not a small area. So otherwise, if you can't go to the customer counter, the only way that you can find AED, probably you can just contact the police. If you can find this pretty lady police, they will guide you how to get the AED. How about the MTR? You can't find MTR in the MTR station, but they have. What you need to do is to press the emergency button to alert the driver and so that there's someone collapsed in the compartment, so that they can alert you. And in fact, with comparison to overseas, for U.S. airports, they've all this kind of signage, just like the fire extinguisher. And they set up every 1.5 minutes walk, you can find one AED. And also they have signage, and also when you open the door, there will be automated activation system to the EMS system. So this is a very sophisticated and well-developed system in U.S., but in Hong Kong, unfortunately, because we in Hong Kong, which is not a PAD system, it is an AED in public place. We put the AED in a public place, but it was carried by security staff, customer service, and you need to ask them to get it. But in the real case of PAD, you must be assessed by every person, just like a fire extinguisher. So, just in Hong Kong, about 2 years ago, we have our leisure and culture department. They start to install AED in every sports activities. But have you ever read the disclaimer? What's the disclaimer said for trained AED personnel only? It's a little bit ridiculous, because AED, sometimes we all usually call it 傻瓜機, okay? Everyone can do it, because when you just turn it on, either by press on the button or open the cover, there will be a voice prompt. The voice prompt will be in Cantonese in most of the case. They will teach you how to use the AED, and you can just follow the voice prompt and operate the AED. And even though some people will have some myth that, what will happen if I defibrillate wrong to a patient who actually did not require defibrillation? So this is not your responsibility. It's the liability and responsibility for the AED company. They will sue the company for the wrong interpretations. It's not you. So actually, we need more AED. You can see that in Japan, they have AED in the center machine. In UK, they have the AED in the telephone. That is one I take from the Mountain Hut in the Mount Fuji. Mount Fuji is 3,700 high. Every mountain hut, they have AED. So probably that's why Hong Kong is left behind. Even though technology can help, they have the different kinds of the AED locator. You just turn on the apps from the mobile phone, the smartphone, they will tell you where will be the nearest AED. You can know where to get the AED to save the patients. So that is what I want to tell about. And this is just a summary for the AHA BLS guideline, New York guidelines. And since safety, and after you notice that the patient is unresponsive, you call for help. And also you try to assess whether the patient is in breathing and pulse. For those patients who have no normal breathing, have a pulse, we can just put in patient or monitor patient, we call it position, but no breathing, no breathing or in abnormal breathing, we try to start the CPR 30 to 2, and in a rate of 100 to 120 per minute, and in a depth of 5 to 6 cm. If AED arrives, we try to use the AED to analyze the rhythm, shock rhythm before the voice phone to defibrillate patient. If not, we continue the CPR until the paramedics arrive. So just some last message, although some of this probably has been covered by the previous speakers. What organizers can do to make sure that we can have a safe environment, a safe event for sports? Well, we need to assess, make some risk assessment. We need to assess the numbers or about the risk of the participants, the nature of the sports, and the events. Any environmental factor, especially the weather. If you are going to hold an event in the hot, humid summer in Hong Kong, probably there will be a lot of casualties. Spectators should not be underestimated, because when there's an event, there will be a lot of spectators around the event. We need to make sure the safety. Just like, for example, if we are going to hold a Formula E event, there will be a lot of spectators. How can we protect the spectators? And even so, we need to estimate the number of the first aid station required, the site where to put it, to set up that first aid station, how many first aid and levels, the equipment, the number of AED, and even we have the medication. This was the picture that I was taken during the Osaka Marathon. You can notice that there's a doctor in Japanese. In fact, they have the doctors invited to run, and they had specialized vest so that everybody knows he's a doctor. In case they need help, you can call for them. Well, in fact, I hope the Hong Kong AAA will consider this and invite us to help. Because in that case, I don't need to stay at the computer early in the morning to compete for others to get a quota for Hong Kong Marathon. So, lastly, I just to share some of the experience by the Hong Kong, but not by the Hong Kong, the Tokyo Marathon. I need to say thanks to my friends, Japanese friends, Professor Tanaka. He was the medical chief director for the Tokyo Marathon. You can see that this 2014, they said they have more than 1 million spectators with 36,000 participants, and you can see that they have lots of doctors, nurses, and probably this is a EMT. Well, this is a EMT. Well, they have 40 running doctors. So you can see that they have more than 600 volunteers to help to make sure the event is safe. And in fact, there was a case in 2009. There was a gentleman who developed cardiac arrest during the Tokyo Marathon. Just within 3 minutes, the AED arrived and shocked him just one shock. And you can see that 12 days later, he was so cheerful to share his experience. And in fact, based on the experience of the Tokyo Marathon, they have 7 cardiac arrest cases in the past 7 to 8 years. The survival rate was 100%. 100%. Every cardiac arrest is safe because they have the very quick response so that they can start CPR and AED as soon as possible. So lastly, well, this was a final message for BLS, although we have some update, but the most important issue will be early recognition, rapid activation EMS. High quality CPR should not be underestimated, and early defibrillation is very important. In Hong Kong, definitely we need more AED, and hopefully we have some legal protection. We have the Symposium law to protect all the volunteer first aider. And this was my last slide. Do you still remember my story? He was the victims. Fortunately, with the help from we have the 2 doctors, including me, 3 paramedics as helpers at that time. We started resuscitation, and within 8 minutes, the ambulance arrived, and just by 1 shot of AED, he returned pulse, and he survived. We make friends, and so this is a happy ending for us, and thank you very much.